Knowing at which point in the course of disease progression a drug for geographic atrophy could be most effective may be key to unlocking a treatment paradigm if a drug is approved.
What late-breaking data presented at the 2021 AAO annual meeting could help inform Retina's eventual strategy to treat GA?
I'm Scott Kriswanis here with Greg Notstein, and this is New Retina Radio's coverage of late-breaking papers from the 2021 AAO annual meeting.
We spoke with Dr. David Lally about his presentation on a post-hoc analysis of the GATHER1 study to learn more about how GA patients who received Zimura progressed from nascent disease to more advanced disease.
And we heard from Dr. Veeral Sheth about the Phase 2b ALTISSIMO study, which explored the use of GB102 for the treatment of wet AMD. Just how long might a drug administered only twice a year provide relief to wet AMD patients? Stay with us to find out.
Retina is racing toward finding a drug that can treat geographic atrophy. With that in mind, researchers who are investigating various candidates for GA therapy are also exploring which dynamics of disease progression may inform future therapeutic strategies.
At this year's AAO meeting, Dr. David Lally presented data from a post-hoc analysis of the GATHER1 trial. His study examined nascent GA and intermediate AMD progression among those who were enrolled in the study, which is a pivotal trial exploring the safety and efficacy of avacincaptad pegol, also called Zimura, for geographic atrophy.
And we're lucky enough to have Dr. David Lally join us today on New Retina Radio. Dr. Lally practices with New England Retina Consultants in Springfield, Massachusetts. Thank you so much for joining us today.
Well, hi, Scott and Greg. It's a pleasure to be here with you today.
We want to hear about the post-hoc analysis, but first, give us the top-line details from GATHER1.
Yeah, sure. So GATHER1 was the first pivotal phase 3 trial investigating Zimura for the treatment of geographic atrophy. And this was an international, it was multi-centered, double-mass study where they enrolled 286 patients. And these patients received either Zimura 1 milligram or 2 milligram or 4 milligram doses or sham injections monthly for 18 months. And Zimura met its primary efficacy endpoint of statistical significance at month 12, with a reduction in the mean rate of GA growth of about 27% in the Zimura 2 milligram dose group compared to sham, and about a 28% reduction for the Zimura 4 milligram dose treated group compared to sham. And then the 18-month results have come out as well and also show sustained reductions in GA growth rates of about 28% for the Zimura 2 milligram group compared to sham, and about 30% for the Zimura 4 milligram group compared to sham. So we're seeing that the efficacy does extend at least to 18 months at this point. Importantly, from a safety perspective, there was no Zimura-related inflammation or endophthalmitis, and there was no Zimura-related adverse events reported by investigators in the trial. The rate of CNV development was slightly higher in the Zimura-treated arms, with a 12% rate in the 2 milligram group in the study eye compared to 3% in the sham-treated eyes. So that is one thing to be aware of.
Let's get to the post-hoc analysis. What were you looking for?
Yeah, so it starts with the development of the classification of atrophy meeting program, the CAM program, which was this group of worldwide experts that formed this program where they determined that OCT would be the optimal imaging modality to study earlier disease in AMD. And this group was able to define two important recent terms that we all need to be aware of. The first being C-RORA, which is complete retinal and outer retinal atrophy, which is essentially geographic atrophy on OCT. And then they also defined I-RORA, which is incomplete RPE and outer retinal atrophy, which is essentially nascent GA on OCT. So with these newly defined terms from the CAM program, we now have an opportunity to try and apply these terms to our clinical trials. And so in this case, we asked two questions. The first question is Can Zimura reduce progression from iRORA to cRORA over 18 months? And can Zimura reduce the progression from drusen to either iRORA or cRORA over 18 months?
Following up on that, why would tracking development from iRORA to cRORA be so important?
Yeah, well, I think we would all agree that if we could, we'd like to intervene as early as possible in the treatment of our patients with AMD. And that means before we see geographic atrophy in these eyes. But in order to achieve that goal, we need to have earlier endpoints to describe the progression of these earlier stages of AMD before the development of atrophy. And having these earlier endpoints will allow us to design protocols with interventional therapies targeting this earlier stage disease, for which we can understand if those therapies have a meaningful effect in the treatment of the earlier stage of the disease.
Let's get back to the post hoc analysis. Review the structure for us.
Sure. So this was a post hoc analysis where the Doheny Reading Center was able to look at all of the OCT data from the GATHER1 study. And they specifically focused on the OCT scans looking at areas beyond the border of the atrophy. So specifically 500 microns from the border of the atrophy. And this was an assessment done by masked graders, which means they had no understanding or knowledge of whether the patient was treated with sham or treated with Zimura. And patients were included if they were randomized into the GATHER1 study and they received at least one dose of the study drug. And so this is an intent to treat analysis. It had to have at least, at baseline, a gradable image, as well as having follow-up images. And the readers were looking for the presence of iRORA and at least drusen at baseline, because that's what we were looking to see, is if there was progression from those two types of lesions. Any eye in the GATHER1 study that developed CNV during the course of this trial was excluded from this analysis. And other exclusionary criteria would have been if they had poor screening images on OCT at baseline.
And what did the readers find?
Yes, to the most interesting stuff. So looking at the progression from iRORA to cRORA, or basically we're talking about going from nascent GA to GA, we found there was an approximately a 50% reduction in the rate of progression in the Zimura-treated patients compared to the sham group at month 12. So while 18% of the iRORA went to cRORA at this time point in the sham group, only 8% of the iRORA went to cRORA in the Zimura group. And this is an effect you can see very early on, even beginning at month 6. And we see that the gap appears to widen between the Zimura-treated group and the sham group over time through at least month 18. And then what about even earlier disease? When we look at progression from drusen to iRORA or cRORA, and again, we observed a consistent reduction of progression in the Zimura-treated eyes that began early at 6 months and persisted through 18 months. But what's really exciting is that between months 12 and month 18, there was no progression of the Zimura group at all. It stayed at 7.6% of the Zimura-treated eyes going from drusen to either iRORA or cRORA at month 12 and month 18. And this is different from what we saw in the sham group, where we saw continued progression between months 12 and month 18. So this is a post hoc analysis, and it should be interpreted as a hypothesis generating only study. But it does raise this hypothesis whether Zimura has the potential to significantly slow down or even stop the progression of drusen to atrophy over time.
Obviously, that lack of progression from month 12 to month 18 is very important, obviously significant. Was it significant between months 6 and 12 and months 0 and 6 also?
Yeah, so at month 6, we saw that 4% of the Zimura-treated arms had some evidence of drusen progressing to either iRORA or cRORA, compared to 16% in the sham group. So it's going from 16% down to 4%, which is a 75% reduction at that early time point at 6 months. So yeah, I'd say that's significant. And the fact that afterwards at month 12, we see it completely stop is even more exciting. So it may take 6 months until this drug has the capability of stopping any further progression. But again, it's a post hoc analysis, and I have to emphasize that there are further studies that are required to better understand the effect of Zimura in slowing the progression from drusen to IRORA or CRORA.
Still, post hoc or not, it's compelling data. Thanks for sharing it with us, Dr. Lally.
Absolutely. Thanks, guys. Have a great day.
Retina researchers have articulated the burden associated with frequent dosing schedules for wet AMD, so it comes as no surprise that pipeline candidates seek to maintain or even improve efficacy compared with current therapies while also extending the interval between treatments. But how close are we to achieving that goal for a widespread population?
We think we're a little bit closer. Perhaps, maybe. There are at least some phase 2b data worth exploring on this topic. And for that, let's bring in Dr. Veeral Sheth. Dr. Sheth shares data from the phase 2b ALTISSIMO extension study at this year's AAO annual meeting.
Dr. Sheth practices at University Retina in Chicago and has been on New Retina Radio a few times. Dr. Sheth, thanks for returning.
Scott and Greg, it's a pleasure to be back on the show with you and the New Retina Radio team. Thanks to all of you for having me back.
Absolutely. The phase 2b ALTISSIMO study examined the safety and efficacy of GB102. Let's talk about the drug design before we get into the study itself.
Yeah, no, I think that's a great idea. There's a couple of things to really talk about with this drug. So GB102 is a proprietary sustained release formulation of sunitinib. Sunitinib is interesting because it's a TKI pan-VEGF inhibitor. So this means it works a little differently than the current standard of care medications which we have, which block VEGF-A. Sunitinib can block VEGF-A, but also B, C, and D. So that's one unique thing about it. The sustained release depot formulation allows for the drug to be delivered via an intravitreal injection and allows for the drug to release over an extended period of time. So that's another kind of unique aspect of this. The phase 2b ALTISSIMO study began looking at a 1 milligram dose of GB102 and a 2 milligram dose, but later moved to examining only the 1 milligram dose.
Let's talk about the study itself. How was it designed?
Yeah, so the study looked at GB102 and compared it to aflibercept for wet AMD therapy. So these were patients that had already been previously diagnosed with wet AMD, had been treated sometime within the last 18 months, and had at least 3 injections of standard of care. The primary endpoint of the study was the median time until the supplemental anti-VEGF injection was needed. And the secondary endpoints included BCVA and anatomic data such as central subfield thickness and, of course, safety data as well. We found that in the median time to supplemental therapy in the study was 5 months in the GB102 arm.
Now, that was considered the core study. You're here to talk about the extension study. Can you tell us more about that?
Yeah, so this was really the focus of my podium talk. And so, that, like you said, was the core study. That ended at 1 year, which was 6 months after the second dose of GB102 was administered. But we wanted to know, could patients continue and not need supplemental injections beyond that? So we followed them for another 6 months beyond that 1 year core study. We enrolled 58% of the patients in this core study into the extension.
Tell us about your findings.
We found that 55% of the patients were able to last 12 months without the need for another injection. So this means that they lasted the final 6 months of the core study, and as well as 6 months further into the extension study. So this translates ultimately to a 73% reduction in the treatment burden for these patients.
Okay, so phase 2b is complete. What's next for GB102?
Yeah, I think that Graybug and providers like us were encouraged by the extension study. And I think at this moment, Graybug is continuing to refine the formulation of the depot injection. And I, like you guys, look forward to hearing where things are going to go next.
Dr. Sheth, it's always a pleasure to have you here on New Retina Radio.
Thank you guys for having me back on the show. More importantly, I want to thank you guys and the team for continuing to shine a light on the work being done in this space. Thanks a lot. Thanks a lot.
That's all for this episode of New Retina Radio's coverage of late-breaking papers from the 2021 AAO annual meeting.
We'll have more coverage of late breakers coming up, so be sure to like and subscribe to the podcast to get those episodes.